Hello, Dr. Cabal.
Hi, Dr. Rodriguez. It's nice to see you.
It's nice to see you as well. I have a question. So this morning I called into the office of the Ministry of Public Health because the new government is planning extensive changes in the healthcare system. So they want us to reassess the effectiveness of interventions aimed at the treatment of chronic disease. So my question is, or what do you suggest? Should psychotherapy exercise after elective unilateral total knee arthroplasty be supported by the government? Is it effective?
Oh, that's a very interesting question, and it's like the topic we've been working on. But I think to give them a recommendation on whereas physiotherapy should be sponsored, we need to run a meta-analysis, or what do you think?
Sounds interesting. I think it could be valid to run a meta analysis because they want to realize the meta analysis. Or well, we want to realize the meta analysis because patients who undergoes knee arthroplasties might experience functional impairments after the surgery. I personally believe that physiotherapy can be effective after the treatment discharge, after the patient discharge, and can make great impact in functional recovery of the knee.
Okay, so let's discuss a bit more about this so we can conduct it. What strategies do you think can help us to include more trials in our meta-analysis?
Sure. Before we start to mention the different strategies that we can use in order to run like a properly meta-analysis, I was reading a comment on Rivers by Dr. Irene when she mentioned very well the importance, and she remains the steps of the meta-analysis. We have to get clear that the different steps of meta-analysis are identification of relevant studies, establishing inclusion and exclusion criteria, data abstraction and acquisitions, data analysis, disseminations of result, and conclusion. So I think that regarding to meta-analysis, studies might not necessarily be equal in their design, but they need to have similar hypotheses. Meta-analysis can be performed using several outcomes. For example, Professor Felipe mentions in the book that for the dichotomous outcomes, risk ratio, odds ratios, and even risk differences can be used. So in this example, we can say that ordinal outcomes can be analyzed using the same strategies as the dichotomous. What does that mean? Another strategy that definitely will help us to understand the meta-analysis in this case is that if we broaden in inclusion criteria, will help to have more data and greater generability because by including a small studies with low quality, we might bias and the analysis, and we might bias the results. So I think that if we use meta-analysis, definitely it will help us. It will help broadening inclusion criteria.
Okay.
What do you?
I think that's a very important point. And for meta-analysis, it's like conducting a clinical trial, we have to specify our research question, which in this case would be, is physiotherapy effective after unilateral total knee arthroplasty? And we would have to determine and specify our inclusion and exclusion criteria. So I do think for including more trials, we do need to broaden our inclusion criteria, as you're mentioning. But I was also thinking that we could try to retrieve as well and publish data. And for these, Dr. Nagla was suggesting, she sent us a message through River, and she was suggesting that we should take a look into clinicaltrials.gov, for example, and see all those studies that have been completed but have no published results. And we could try to reach for those researchers and ask them if they can provide us with the results. We could also, as Dr. Julia Belanda suggested, call farm databases to see if they can give us some data regarding studies that have not been published, because sometimes we can have reporting and publishing bias in which only those with positive results get published, and we want to avoid this.
Yeah, so I'll agree. That's very interesting because something that I noticed and was interesting to me that the most important things is that we assess the differences between treatments. We can have an heterogeneities like studies, and this is how can we avoid bias and other stuff. That sounds very interesting, Dr. But I have a question. So how can we publish data to be found?
I think we can do it just as we have mentioned, like looking for clinicaltrials.gov and trying to contact researchers and asking them, like, we've noticed you registered a trial, but we don't have the results. Can you provide us with the results? Or so seeing some pharmacist databases, and also we can talk with other experts, and they might know of researchers that ran the trial but never got to publish them. So we could do this, and it's an exhaustive research, but I think just by limiting us to publish data in PubMed, and then based on that, we would be withholding ourselves from other studies.
Yeah, interesting. Regardless to the pros and cons of including trials with different designs and qualities of the analysis, how can you deal with the problem?
That's a very interesting question, and I think, well, the pros are that we would have like heterogeneous results and heterogeneous studies, and that can help us, for example, in extrapolating the results, like for external validity. So heterogeneity isn't a bad thing for meta-analysis, but we also would have to analyze our heterogeneity with caution and apply statistical tests and analysis to see where this heterogeneity comes from. And we can even test heterogeneity with Cochrane's Q test and things like this. So I think it has pros, but we would be like, once we specify these inclusion and exclusion criteria, we would allow for some heterogeneity to be there, but we can also then recur to statistical analysis in order to get conclusions despite this heterogeneity.
Yeah, totally agree with you.
I don't know, have you heard of the Cochrane's collaboration?
Yeah, actually, Julia has posed, she has described nicely like the main concepts of the concrete collaboration. And she says that the main purpose is to develop systematic reviews of the strongest evidence available for healthcare intervention. I think so this is very important because it can help through provision of relevant, useful information, as Nagla has mentioned as well. So this is very useful.
And now that you were mentioning heterogeneity, I was also it comes to my mind. Mm-hmm. And I think you noticed in our group project that we were working with several depression scales and choosing one, but in meta-analysis in depression, they encounter that outcomes are measured with different scales, and for arthritis, it will be the same scenario. So we can just or categorize or standardize the outcome, or we could even use set of scores that have no units, so we could compare them, and then we have this test depending on, as you mentioned at the beginning, if they're continuous or categorical outcomes. And for continuous, we could use Cohen or Hedges G test, so that way we won't limit ourselves by the type of scale they were using.
Mm-hmm. So I found a way how they categorize using score systems concerned with randomization strategies and concealment. Let me see if I can share this picture with you in order that we can understand better. Let's see. I don't know if you can take a look of the screen, if you can see the screen. Can you see the pictures in the screen?
Yeah. Okay. Yes, we can see it. Mm-hmm.
This example is an example of a result of the scoring system that is used or is commonly used for describe the concurrent collaboration. So, and also that represent the percentage of system, it's like a systematic reviewing protocols for treatments used by the concrete groups. In these pictures, we can see what is the high risk of bias related to the concrete groups, what is the low risk and what is the clear risk of bias. You can see that the green colors represent the low risk of bias, related to the random sequence regenerations, allocation concealments, bindings, incomplete outcomes data, selective reportings, and others. So the red colors of the pictures, as you can see here, represent high risk of bias, and it includes selections bias, also including participants, personals, outcomes assessors, attrition bias, reporting bias, and others. And the yellow represent the employer risk bias. But what is interesting to me is, like, as always, Professor Felipe says, it doesn't matter which method we decide, we always have to give a good reasoning thinking about what we want to choose, but all of them can be useful because all of them is biased at the end of the day. So I think this is it. So I think so we get clear about what the government want to assess, and it was very clear after discussing with you this interesting topic. So thank you so much for having your time to discuss this topic.
Wow. Thank you, Dr. Lasker.